Welcome to the last session of the day. I've got the privilege of standing in for Joanna Hikaka. And my name is Ulrich Birchler. I'm part of the University of Otago. And it's my privilege to introduce Sue MacDonell. Sue is a New Zealand registered dietitian who works in the nutrition department at the University of Auckland. I hope there's plenty of good things to eat. She has a practice and research interest in how best to identify those who are malnourished in Aotearoa, New Zealand. Sue is chair of the National Malnutrition Steering Group and teaches on the Dietetic Master of Health Science. Lots of tongue twisters. So your talk, how well does interRAI-AC malnutrition cap predict malnutrition risk for Māori and non-Māori inpatients of a New Zealand hospital? Welcome.
As Ulrich said, I'm going to just introduce you to a little bit of work that is actually part of one of our master's students' projects. Molly's planning to submit this week, so it's really nice to be able to start getting her results out there. So she did some work looking at the malnutrition risk in New Zealand hospitals, and as part of this, we're looking at the interRAI acute care undernutrition cap. And I guess one thing to say before we get too much further is that the undernutrition cap or the acute care tool actually applies to adults of all ages. It's not just for older adults, so it is slightly different, this setting. It was a collaborative project between ourselves at the University of Auckland, Professor Matthew Parsons, whose name has popped up on a number of presentations this afternoon from Waikato University, and we worked very closely with a group of dietitians at Te Whatu Ora Waikato Hospital. So that was where the study was based. We don't have any conflicts or funding to declare. I just want to set the scene a little bit. I never miss the opportunity to talk about malnutrition, what it is and why it's a problem. So bear with me, I'll set the scene a little bit with the background. So in the health setting, we're really talking about a state that results usually from a chronic or acute conditions, or it might purely be just to starvation. And it's usually because people aren't able to eat enough food, or the food that they eat, they're not able to digest or absorb the nutrients from to meet their requirements. And what happens when we've got a prolonged reduced or a gap between what we need and what we're eating is that we start to lose muscle mass and we start to lose fat-free mass. And that results in a reduced physical function. It affects our cognition and our mental abilities to think and to do things, and then impaired clinical outcomes such as reduced wound healing, a greater risk of pressure injuries, reduced immune function, and all of that, apart from the personal costs of malnutrition, also then start to impact on the actual resources and the financing of patients as well. So they have a longer length of stay, they're more likely to be readmitted back into hospital as a result if they're malnourished when they're discharged. Malnutrition is sort of a two-step process. We start with a screening of risk of malnutrition. So it doesn't actually say that this person is malnourished. It just highlights that they're at greater risk of actually having malnutrition. And that, if it is positive, then triggers a full nutrition assessment. So this study really came about because there's no mandated malnutrition screening in New Zealand hospitals. There's only one district that actually has a set policy that means that every patient is to be screened when they come in. Other hospitals do malnutrition screening, but we did some clinical audits last year and it's a little bit hit and miss as to whether it happens or not. And there was no screening at all happening in Te Whatu Ora Waikato. The prevalence of malnutrition in acute care ranges from about 20% to as high as 50%. So up to half of our inpatients can suffer from malnutrition. But when we looked at the coding analysis at Waikato, they were actually having fewer than 1% of their patients diagnosed with malnutrition. So that sort of raised some alarm bells, and I was thinking there's a whole cohort of patients there that have probably missed treatment or not been identified and therefore are not getting optimal care, certainly not nutritional care. At the same time, the interRAI acute care assessment was then required by ACC for anybody on a non-acute rehabilitation pathway or a NARP pathway. And the undernutrition cap raised also some concerns with dietitians because it doesn't necessarily carry a number of the components that validated screening tools that have been validated internationally, not in New Zealand, but doesn't have those components as part of it. In particular, it relies on body mass index, and we could do a whole different session on why body mass index is such an issue at the moment. And suffice to say that it started out as a population measure of wellness, and it has been converted, like so many things, to being a measure of individual health. And so just because we carry a high BMI doesn't mean that we're necessarily unhealthy. It tends to be happening what's under the skin that we don't necessarily see. So what we aim to do was to determine, as part of a larger point prevalence study around malnutrition at Waikato, was to determine the ability of the interRAI-AC undernutrition CAT, or clinical assessment protocol, and the malnutrition screening tool, which is a validated malnutrition screening tool internationally, and to see which predicted malnutrition in adult inpatients when compared to the subjective global assessment, which is a comprehensive nutrition assessment, which I'll talk you through in just a moment. So we surveyed 220 adult inpatients over a 24-hour period at Waikato Hospital. Most wards were included except those that we knew that were a low risk of malnutrition. So we didn't include, for instance, postnatal or mental health. None of the pediatric wards were included because it really was just an adult study. And we didn't look at the emergency department or day stay. So the data was all collected by 20 dietitians who were taken off their usual duties for a 10-hour period and collected the data, which Molly and myself have then gone on to have a look at. So this is our data collection form. Essentially, what we did was the dietitians collected all of the data that would be collected for malnutrition screening, but they didn't calculate the malnutrition risk. So the data was collected, they might have added it up in their head, some of them would know it, but it wasn't actually calculated at the time. And so the malnutrition screening tool has 2 questions. It asks about unintentional weight loss, and it also asks about poor appetite and whether your food intake has reduced because of a poor appetite. The interRAI-AC undernutrition cap, as I said, measures body mass index, which needs a measurement of weight and also of height. And because it's very rare for New Zealand hospital patients to have their height measured, the dietitians undertook ulnar length measurements, which we then converted to height, so that we had heights for everybody. But as you'll see as we go through, we didn't have weights for everybody, because not only do heights not get measured, weights don't necessarily get measured either. The other thing that the interRAI-AC cap looks at is weight loss as well. So those 2 things are common to both screening tools. They then went on to do this subjective global assessment, and the form's quite little, I apologise. But essentially what it does is look at nutrient intake, it looks at the past weight, so it also looks at weight history, which does raise some problems when we're starting to validate against the same sort of data. It looks at nutrition impact symptoms like nausea and gastrointestinal upset. It looks at changes in functional capacity, and then it also looks at doing a fat and muscle assessment. So it's a physical assessment where we palpate different sites of the body. So this is one that you can do yourself. This is the interosseous muscle, which is between the thumb and the forefinger. So if you pinch your thumb and forefinger together, and pinch really hard, you'll be able to feel that muscle there. It's a little bit like testing cooked steak. If it's really firm, like a well-done steak, you've got good muscle mass. If it's a bit spongy, then you're on the rare side and you don't have a lot of muscle there. So what we look for is scooping. Women tend to scoop a little bit more naturally anyway, but if you lose muscle from this part of your body, then it actually does hollow quite a bit. It used to be called the snuff box back in the day where people were taking snuff, and it's where that would sit. So that's something that I can assess without actually hands-on and start to look. Okay, just an example of the sort of assessment that we're doing. So this is the demographics from the cohort. We had a quarter of our participants identified as Māori, and that was fairly reflective of the inpatient population on the day at Waikato. It was sort of slightly fewer female than males across both cohort groups, and a slightly younger population than perhaps we might expect, with just under half of non-Māori being greater than 65, but less than 40%, which is indicative of that different life expectancy for Māori versus non-Māori. And as you can see, most of the patients were in a medical or a surgical ward, which we have grouped together for the purposes of data analysis. So what did we find? If we have a look at the risk results, you can see, and I've just put them in by the 2 different cohorts, Māori and non-Māori, that the you want those? Nope, that one. Okay, so I was just pointing out that we found quite a high prevalence of malnutrition in this population on that day. So we do need to remember that this is very much a slice in time. But if you remember that the coding analysis found fewer than 1%, it's quite obvious that they were missing quite a number of patients that would have benefited from some sort of nutrition intervention and treatment. This is a really complicated table that still does my head in, but if you look at the slightly darker squares, these are the total positives and true positives and true negatives. So comparing down the left-hand side, the two screening tools, the interRAI-AC at the top and the MST at the bottom versus the subjective global assessment across the top. So whether they were diagnosed as malnourished or not malnourished for each of the three cohorts. And I've done some quick calculations today, actually. Thank you to Christian and his presentation. I went back and calculated accuracy. So thank you, that was really helpful. So you can see, which is a little bit easier to understand sometimes than sensitivity and specificity. But you can see that the interRAI was certainly having a lower overall accuracy compared to the MST. And for Māori, it was as low as 67%. Not quite so low with the non-Māori, but still probably not either of them where we really hope to be for a screening tool. I mean, the higher these results are, the more likely they are to actually be picking up people that have got a problem. If we do look at sensitivity and specificity, so sensitivity is where the tool actually picks up those people that are malnourished and doesn't miss the people who aren't, whereas specificity works in the opposite almost. It picks up those who are truly not malnourished. Again, just looking at the two cohorts of Māori and non-Māori, you can see that, in fact, if I go to this one, that's a little bit better. I've graded them for you rather than looking at the numbers. The MST for non-Māori was graded as excellent. It was doing a good job of picking up those people that were malnourished, but it had a fair specificity. And similarly, the interRAI had a fair sensitivity and specificity for non-Māori. If we look at the Māori cohort, both tools didn't do such a good job. And the MST, though, was still doing a slightly better job at identifying those that were actually malnourished. So what does that mean? First of all, there's a high prevalence of malnutrition in our New Zealand hospitals. So I'll put a plug in here that we've just convened a national steering group for developing guidelines around how to manage malnutrition across the spectrum of care. So this is not just in hospitals, but we're also looking at primary health care and also aged residential care to actually come up with some guidelines so that people know what needs to happen to pick these patients up. We did find that the interRAI-AC under nutrition cap had a lower ability to predict malnutrition compared to the MST, and particularly for Māori participants. And I think what it did was underline our concerns around body mass index. That if we look at population statistics, BMI for Māori tends to be higher. And even though it's nice to see actually in the acute care cap, the cutoff for BMI is a little bit higher. In aged care, the cutoff for the undernutrition cap is 18.5. And if you've got a body mass index of 18.5 and haven't always had it for life, but you've suddenly got that, it's a late intervention for people to suddenly be correcting. So what I'd really like to see is that I know that the interRAI is a rich data source and that there must be other factors that we're collecting that would actually do a better job at predicting malnutrition. So I've already talked to Christian today because I think AI has a bit of a role here to play and look and see what other things, but I'm thinking around things like dentition, the type of diet that people are on when they're in hospital or when they're in aged care, even cognition. We know that there are other risk factors for malnutrition. And then we really need to have a look at the undernutrition caps and the other interRAI-AC tools, which also depend quite heavily on body mass index. So thank you.
Just wondering, I know that some of the dietitians were speaking to Len Gray about the acute care, so that those conversations are still happening.
Now that we've got our data, we'll definitely be getting that back to Len. I know he's a strong advocate of the acute care tool, so we really want to make sure that he's looking at this. We both share some concerns around our methods of validation. So yeah.